A very good morning to all of you. In the interest of time, since Dr. Pooja is slightly delayed, I'll be starting with my talk on intracorneal ring segments in keratoconus. Now, just to place things in context, we know that C3R can stabilize a keratoconic cornea, and once you have a stable cornea, we now look at the second stage of visually rehabilitating these patients through refractive means. Contact lenses remain the simplest and perhaps one of the best modalities for patients with KC. However, there are patients who are intolerant to contact lenses, and we have three main modalities of topo-guided PRK, phakic IOLs, and intracorneal ring segments for these patients. Now, when we have a central cone with a low degree of refractive error, morning, sir. A central cone with a low degree of refractive error can be treated with a topo PRK, classically for mild to moderate cases. A central cone with a higher amount of refractive error can be treated with a phakic IOL. Now, the eccentric cone, which basically means that the keratoconic cornea has a high degree of irregularity, needs some regularization. Regularization of such an eccentric cone and moderate keratoconus is best done with an intracorneal ring segment. I'll just be telling you what these are and how they are to be used. Now, ICRS are basically tiny arcs of PMMA. They are implanted in the corneal stroma. What happens when you implant them is that they function as a spacer device. What does a spacer device do? You can just imagine a hammock or a tightly stretched curved rope. If you put in two spacer devices, what will happen to the tension across the hammock? It will become less tense, it will have less stress on it, and the central portion will become flatter. So what is an ICRS doing? It is basically flattening the central area, and it is also redistributing the biomechanical stress forces. So in effect, we have three outcomes. The cornea becomes more regular, the central area becomes flatter, therefore the refractive error reduces, the vision improves. And the third important factor is, because of the redistribution of biomechanical stress forces, it adds value to stopping the progression of keratoconus. So, who are the patients who are fit for ICRS? Classically, we do it in patients with a visual acuity with spectacles best corrected worse than 6/9. Because ICRS is not pure mathematics. If you do it in a 6/6 spectacle corrected patient, they may actually get a little bit of disturbance, because when an eccentric cone becomes central, sometimes a 6/6 patient with spectacles may feel that the aberrations have increased. So classically, take patients with visual acuity worse than 6/9 with spectacles, who have clear central corneas, and the paracentral and peripheral cornea, which is between the 6 to 8 mm zone, where the ICRS will be implanted, should be at least 400 to 450 microns thick. Now, you may think this is a high thickness, but do note this is not a central thickness. So a lot of patients with keratoconus will be eligible for this, because in this area you may have a thick enough cornea. There are various segments that are available. We commonly use the intact segment, but the cost has come down with the biotech company introducing a segment of bio ring. You also have Ferrera rings. What is important to note in this is that basically the cross section of these segments are different. They are done in a way that the negative photopsias associated with a segment implanted close to the pupil are reduced, and whenever you implant anything in the stroma, the forward compression of the stroma as well as the endothelial pressure is minimized using a cross section of basis their research. The preoperative plan of ICRS is akin to what you would do for most keratoconus patients: a good topography and a good refraction. Now, do note that this will influence the segments that you use and how you implant. What is the thickness of the segment that you will use will depend on the amount of correction that you need. So if you're treating a steeper cornea, or if you're treating a cornea which is high in terms of the spherical equivalent, right? These are both indicators of how advanced the keratoconus is. You will need to flatten it more. So you will use a thicker segment. Now, if you have a central cone, you will flatten it symmetrically because you want the whole cornea to be pushed down, but you don't need to displace it. So you will use two similar sized segments or symmetric segments. If you have an asymmetric cone, you will use one thick segment on the portion where the cone is larger. For example, largely it is an infratemporal cone, so the inferior segment will be thicker. Another way of defining symmetric or asymmetric, first is you use the refraction. If the sphere is more than the cylinder, it is a symmetric cone, but the cylinder has to be looked at in a positive connotation. So you transpose so that the cylinder is positive and then see whether you need symmetric or asymmetric. Or you look at the topography. If large part of the cone is outside the 3 to 5 mm zone on the posterior float, okay? So then it is an asymmetric segment that you will go for. Surgically, do implant it at least at a depth of 70%, because if it is too superficial, the forward compression on the stroma and the epithelial breakdown may lead to extrusion. Also, a deeper implantation will give you a better effect. Now, earlier the implantation was done manually, but now we have good femtosecond laser platforms which allow us to create a channel which is made as per the desired diameter and depth. Once this is pre-fashioned, we simply open up the channel with blunt instrumentation. You can sometimes even use the ICRS ring, but I prefer this instrument which first goes vertically and then you turn it into the channel. And following this, you will nudge the ICRS segments into their place. So this is how you hold. There are special forceps to hold the ICRS segments. So there is first a small vertical dip followed by the circumferential movement along the channel. Do note that there are two tiny holes at each of the ends. You can engage them with a Sinskey hook, and this is important because the distal end of the ICRS must be at least 1 to 2 mm away from the incision site. Otherwise, you again risk extrusion. This is the second segment being implanted. I'll just be discussing a few cases. This is the first case. Now you can see the cone here is within the 3 to 5 mm zone. This is in the posterior float. If you see the refraction, if it's transposed into the positive sense, the sphere is more than the cylinder. So you go for symmetric segments. This is what we have done in this case. The axis is chosen as the steep axis, like you do in a cataract surgery. The steep axis can be defined either by your topography or refraction. Normally, because you're treating the refraction, we take the steep axis as the refraction to override the topographic steep axis. If they coincide, well and good. Otherwise, you go for the refractive steep axis. If, however, the keratoconus is too advanced for you to feel that you are bang on the axis, because there's a lot of scissoring and you're unsure about the axis, you may tilt towards the topographic axis. So this is what we have done. You see here that this is, note here that the ICRS is put inside about 1 to 2 mm inside the incision to avoid extrusion. And you also don't make the two segments touch each other, because in case they're touching each other, they will have a torque and they may bend forward. So keep a distance between both the segments. This is the comparison map just to show you that these segments do give you a real improvement in topography and in BCVA. This is the second case. You see this is more of an eccentric cone, and you will put in a thicker segment inferiorly. You may or may not choose to put a thinner segment superiorly. All these things you can get the initial plan from the company and basis your experience, tweak the plan. But for beginners, the plan that the company sends is a reasonable plan, and you can reach out to one of your colleagues for further added inputs. So we normally tend to do cross-linking along with ICRS on the same sitting. If you have to do sequentially, then please do the ICRS first, regularize the cornea, and then do the cross-linking to freeze the regularized cornea, right? There is, of course, an advantage of doing a single sitting of the fact that not only do you save the patient a visit, but also the riboflavin dye pools into the ICRS channels, and the cross-linking of the channels enhances the effect of the ICRS itself. This is just a very important take-home point. This is a lady who came to us with post-LASIK ectasia. You see, this is what she had. This is the cross-linking being done because progression was evident. And this is the progression post the second pregnancy. So cross-linking often is not as effective in post-LASIK ectasia. This is our other eye. You see again there's a central nipple-like protrusion, which is a post-LASIK ectasia central, a steep island, a steepening followed by the island that you see from the ablation. We did an ICRS in this patient, the second eye. First eye was pure cross-linking. This is ICRS. And this is how she was in her second pregnancy. So this is the first eye with just cross-linking, and it has worsened. Okay? So this is the second eye of the same patient with ICRS, which is actually better. So this really goes to prove that ICRS is a very important modality in post-LASIK ectasia, and it has an additional role of redistribution of the biomechanical stress forces, which reduces the progression of ectatic corneal disorders. I'll just show you that ICRS can sometimes always have complications like a reaction or an extrusion. This is a melt. If you have a corneal melt, cornea will never epithelize over the PMMA segment. So you will need to take out the ICRS. You can prevent it by really treating with steroids any initial inflammation, particularly the VKC associated with these patients, so that it doesn't progress to this. But in case it has, you have to remove the segment. Cornea is a very forgiving tissue, and usually it does heal back with no significant long-term damage. This is what I was talking about. Sometimes these melts are preceded by white cell reactions. So treat the corneal surface, respect the corneal surface before doing any procedure like an additive surgery. This is again another melt. This was during the COVID lockdown, and I did not have access. It's right in the center. If the melt is in the distal end, you can simply hook it out and take it out. In case the melt is in the center, I'm going to make a deroofing T incision because you have to access the ICRS through the small holes in the distal and proximal ends. Then you engage it and simply wheel it out. So this is the wheeling out of the ICRS segments. And the cornea subsequently does epithelize. I think we are blessed with one of the best tissues in the eye, and this is the healing process that has happened. Some of the effect of the ICRS still maintains if it's been in the eye for many years because there has been a scarring along it. So all in all, ICRS is a very useful modality in the treatment of keratoconus and post-LASIK ectasia. Complications, though, can be there if identified and treated well, do not leave any dangerous sequelae. Thank you for your attention.
Thank you, Ritika. It was a wonderful presentation. We all know keratoconus is a disease which is progressive and sometimes very difficult to manage to give a very nice optical rehabilitation. In a selected cases, different procedure will apply and they can give you a good outcome also. And intracorneal ring segment has been there for quite a long time, and they will also give a suitable outcome for our patient in a selected case, which Dr. Ritika nicely showed, which are those cases where you'll have a benefit of ICRS and the outcome. And 2 or 3 things are important here, which may be important in terms of patient counseling also. One is it's going to improve the quality of vision, which may be with the segment itself in a low to moderate cases, or the subsequent rehabilitation with spectacles or a contact lens will be better. In fact, many indication may be for improving the contact lens fit in those cases. Other thing is, as she rightly showed, if there is a small number of cases where complication occurs, it's a reversible procedure. Therefore, you can take it out and do other procedure also. You can do a dark procedure if needed. You can do other procedure also. Still, you have a patient's own cornea still there preserved. The third thing is you can combine that with the cross-linking so that your effect is more prominent and lasts for longer time also. So there are 2 or 3 things are very, very important in these cases. As far as segments are concerned, she nicely showed that you can use the symmetrical segment, asymmetric segments. If you are using the asymmetric segment in terms of thickness and size, so you should put a thinner one first, or you put a thicker one first, then go for thinner later, because cornea gets stretched and difficult to insert the thicker one subsequently. And make sure you do it in a manner where things are more visible. So sometimes things can be very, very difficult, and whatever we have seen, the complications are very, very few with experienced hands, and it's a very good alternative for a patient with mild to moderate keratoconus. Thank you, Ritika. Beautiful presentation. Any comments?
Can you exchange ICR segment?
It can be exchanged also, yes.
And what about cares? Any?
Kera? That's another option people are propagating. You can use the segments prepared from the human tissue, which may be working in some patient, but you require a large number of cases to really say that it is effective to all type of cases. And whatever cases we have seen from Sujan and the, they have done really well, except for some cases where there's a continuous haze happening. Luckily, they are in the peripheral area, so may not cause a significant damage to the visual axis. And they are also can be removed also, though they become thinner and gets to the stroma also. But I've seen a haze, especially in those segments, because this is actually the tissue which is not the artery tissue.
Right.
Amit?
Just a short comment, like no doubt that intacs is a part of, the ring segments are a part of what we practice for keratoconus. What visual complications do your patients face? Because that's something which sometimes we have to counsel the patient and
Sir, actually, visually, refractive outcomes are usually, they always get better. There are two problems that actually sometimes come in. I feel contact lens fitting becomes a little tougher post-intacs rather than becoming simpler, because the geometry of the cornea changes. Second is that if a patient has very, very good vision and you're doing a early case, the eccentric cone coming into the center adds to the aberrations in the pupillary area and the quality of vision goes down. Hence, I classically don't advise intacs if the patient has good vision with spectacles of 6/9 or better. The third thing is that it is very important in India. A lot of people hide their disease, and ICRS segment actually is very visible. So that has to be told to the patient, that people will look at your eye and will be able to make out that a procedure has been done. And there are some people who opt out. I feel I always give a contact lens trial to the patient. They have to say no to move on to the ICRS. Patients who have unilateral keratoconus take to ICRS very well, because they never put contact lens because they see with the other eye. So these are the basic things.
yes, correct, because we say contact lens intolerant, but sometimes we are pushed by the patients also,
Yes.
because they come, they read about it and they come to us. My second,
But there are no significant photopic or dysphotopsias that these patients are coming to us with. I have one patient who feels that after the explant there is some scarring, so he says that he's not able to drive as well at night. And to overcome them, you can do contact lens fitting on these patients if they are complaining.
yes, and you give them time, so most of them
Yes,
get used to
they
it.
used to get- and you anyway treat patients who have poorer vision, so they anyway have the ghosting and the problems, so they will not complain. It's not like LASIK that they had perfect vision to start with.
What is your experience with patients where you sometimes might have put in some implants after they have undergone cross-linking?
So there were two
The
things.
usual practice is,
Yeah. First is that the femto sometimes actually misfired for us, because I think that one case I did show today of a perforation. So the femto channel, because of the earlier femtos were a little more sensitive and not as well focused perhaps. Now I don't think we have that problem. So post CXL, the dissection is a little more tedious is what we thought, but it is not so much, because CXL effect is usually in the top part of the stroma and you're going in the deeper part of the stroma, though the overall effect of the ICRS is a little less post CXL. So you can actually go one segment thicker, but whenever you go a segment thicker, you must not be more than 50% of the stroma, because you can melt. And some of the melts that I showed are actually post CXL patients. So please don't think that if they've had CXL they can't melt. They still can melt, because if the ocular surface is bad.
Thank you.
Okay, very nice points. One thing, the suture we put in incision, that should be managed appropriately also. Sometimes if you leave the suture, that access will inside the inflammation, vascularization, and start melting, and you have a problem. So suture is also should be managed effectively in these cases. Earlier, when we used to do a manual surgeries, depth was a major concern, but we never achieved the depth where actually you could implant the intacs in a proper manner. Now with the femtosecond, you are in an appropriate depth, and results are more consistent and predictable. Thank you.